Well, we didn't present it as an alternative to medical care. We randomized the patients to usual care, which is you see the cardiologist every 3 months, or extra telemonitoring. So they might see the doctor more or less often. So we don't say it's a way not to see you. Different from, for example, follow-up of pacemakers, which is also possible already in ICDs. There you could say, okay, we'll see you next year, instead of see you every 3 months or every 6 months as we do now. Liability, who is responsible? So what we put in our contract is that this is not an emergency system. This is a way for early warning. We will contact the patient if we see there is something threatening to happen, but if the patient doesn't feel well, he or she should contact his or her physician, and that's something that needs to be well understood. And also telemonitoring gives the possibility to go over the borders. And in Europe, it's not evident that you would transmit personal data over the borders, so that's another issue. Privacy and safety of these data, that's the things that are now more or less hampering the evolution. I know that as well in Belgium as at the European level, there are some initiatives to try and form a sort of a global legislation on that, but as you know, legislations are formed very slowly, so it's not gonna be solved very soon. So what we do now is we try to have in this contract as well stipulated that what are our responsibilities, and up to now we don't have any problems with patients suing us, but that if you want to expand it to a very large group of patients, you might have patients saying that, well, you didn't see it coming, why am I in the hospital now? So that's the way to go. I think the sensors we used are old school sensors. We used a scale and a blood pressure device already 20 years ago or a longer time ago. So that's the least sophisticated way to follow up patients. You have the new pacemaker devices that tell you things about fluid status and all that have to be integrated. Also, what we do now is you look at the different parameters on their own, whereas the combination of changes in blood pressure and heart rate and maybe activity and weight might give us much more information on what is happening or going to happen with a patient. So there is a lot of evolution towards more interesting sensors, more invasive sensors maybe for the very severe patients, more clever algorithms that might already react on their own without even the nurse intervening, and then the nurse and then the cardiologist. So I think we are already at a stage that it can be clinically used now. It only takes an organization in your own hospital, investment in a heart failure nurse and some material, and then you're set to go, and it's rather easy to start with. But there is much more to come. You would expect that in places where there is little people for large countries, like in some parts of the United States, that it would be adopted earlier. But as far as I know that there are specific places in Europe and in the United States where it is used as a clinical tool already, but often it depends on the personal interest of the physician or the organization. If you tell an insurance company that they might reduce rehospitalizations by almost 50%, well, they would be crazy not to pay for this kind of monitoring. But then again, it depends on how much does it cost locally. I think liability is a much bigger issue in the United States in healthcare than it is in Europe. I see, for example, in the north of Norway, where they have ice on the roads for most of the year, they are investing heavily in the use of telemonitoring. So I think the use in these kinds of rural areas are evident, but we tested it in a city environment, and it works very well also, because these are elderly 70, 80-year-old patients that don't like to drive to the doctor every time. So it can work everywhere. And I think there is also a very promising, it's very promising to use it in countries like India and the developing countries, where you can say, okay, people can stay home and we will call you if there is a problem, instead of, and this can be expanded to all kind of situations like hypertension follow-up. Now the patient goes to see his GP every few months. Well, you could call the patient if there is a problem and leave him at home with his prescriptions. The same for rehabilitation. Cardiac rehabilitation has also been proven to work. You can help patient be more active, eat better food and all that. So these are things that can be implemented even more in developing countries where they don't have the structures that we have now. The thing is that we have been waiting, the results, the clinical results are already in for a few years. We have been waiting for reimbursement and for a solution to the legal problems, liability, things like that. But that's not happening very quickly at the moment. So what we will do now at our hospital is we will implement it as a service, make a contract with the patient. So if you're hospitalized for heart failure, you may be followed up more strictly. We know from our studies that it helps to keep you out of the hospital, but you will have to pay a monthly fee to make sure that we can pay our services. But we won't get rich because of it, I'm sure, but I think we can keep out of the hospital those patients that come only for fluid, for congestion. That's a pity to have them in the hospital for a few days just to give more diuretics and then send them away to see them back 6 weeks later.